So we have a lot of questions from the audience. I'm going to just sort of jump around here a little bit. Maybe I'll start, Alan, with you in the in reviewing the differences between methotrexate from the different guidelines and how they should be used, and then the recent data about even 5 milligrams or less can cause serious infections and also even cardiac events. Has any of this changed any of your use of methotrexate? I'm sorry, of steroids?
Yeah, I think that this represents kind of the field in general, that we're being much more cautious about putting people on glucocorticoids and maintaining people on low-dose glucocorticoids. I came out of the era of gold and bridging therapy for use of low-dose glucocorticoids. So it is a transition for me, but most definitely decreasing the amount of glucocorticoids we use.
I want to encourage our faculty to answer any of the questions, even though I'm directed that at Alan. All of you are invited to answer and provide your answer. I want to also ask the audience here, if you have a question, please come up to the microphone. We'll get you right on camera.
Well, let me make a comment on that. And now I'm Alvin Wells. I have a patient, a real hot rheumatoid. I'm starting them on methotrexate. I don't do what many rheumatologists do. I actually start an appropriate dose of methotrexate, high dose, right? And that patient is hot as a pistol. And if I don't give them steroids right away, they're going to go to the rheumatologist down the block, all right? So I actually believe that the EULAR recommendations are very appropriate, all right? They're very sound, they're very logical, they're based on evidence. The ACR recommendations are really not, all right? So I would still, but I would use exactly as EULAR says. I would start and then taper very, very quickly and let the patient know they're going to taper very quickly.
So I want to ask both Maya and Alan a question from Philip Malloy, which is in assessing disease activity, would you consider using Vectra or even monitoring methotrexate levels in helping you to make a decision? Maya, you want to go first?
So yeah, I mean, I think it's an area that's gained more interest and traction of late, I suppose. It's not something that's been introduced in our routine practice, certainly evaluating methotrexate levels. But I think as we recognize more and more about issues of adherence, and when we're trying to refine, I suppose, the kind of outcomes and effectiveness, there may be in the future where this becomes possible. I think it's all about how the ease and the accuracy and the relevance in terms of our clinical practices. But certainly I think at the moment, it may be slightly premature, mainly because of the kinds of diagnostics and assays that are used. And certainly in the UK, in Europe, it's not routinely applied, because I think there's still some work to do there in terms of our clinical practice, but I suspect it will become maybe more relevant over time.
Alan?
So I've not found those two tests being particularly useful on an empiric basis. And I still think we're looking for, frankly, a better test that's more helpful. I tend to use diagnostic ultrasound as perhaps a judge of active inflammation over those two tests.
So Roy, you recently published on the utility of MBDA. What's your message from that?
So I think that Vectra is a non-useful test. I really was careful with that word.
Are you running for office?
Well, no, I was very careful. It's non-useful. I didn't say garbage. I said non-useful. So the answer to the question is, I just published on RCI, the drug that's too expensive for anybody to use. It should be $2 a week. I have published on baricitinib. I published on abatacept, adalimumab, and it has been published with tocilizumab. The Vectra really does not correlate with any of the disease metrics that we use. So I think it's perfectly worthless for disease metrics. Now, I don't know about radiographic regression. On the fence with that. I'm still kind of thinking that it's not probably as good as other things, but that may be a little bit different.
Roy,
sorry, Jack.
Yes, please, go ahead.
Sorry, Jack, if I could. Yeah, sorry, I think the connection was interrupted, so I thought it was about methotrexate levels, not MBDA, and I entirely agree with Roy. sorry, to clarify, I was talking more about methotrexate levels and polyglutamate. So MBDA, yes, over and above what we use in terms of CRP and ultrasounds, I certainly haven't found any additional utility from the evidence base, just to clarify.
Okay, so unanimity amongst our faculty. Roy, you talked about otilimab, the GMCSF. You know, mavrilimumab got a lot of splash at ACR as an anti-GMCSF in GCA, and it looked very, very good. There's a recent meta-analysis of this showing really uniform success in RA. Why are we not seeing that? What is the future of GMCSF targeted therapy?
So we have to see what the results of the phase 3 trials are. So there were 3 phase 3 trials, 2 versus TOFA, one against ABBA. And so these comparative trials, these are quite good. They're powered head-to-head trials. And we'll see what their efficacy is. My guess is the efficacy will be similar. As I showed before, I think on pain, it may be beneficial, right? And again, this works JAK2, which is very different from everything else we use. The mavrilimumab was effective in RA. AstraZeneca made a business decision to discontinue it, right? So I think we have to see the results of the trial, but I think it's possible.
Alan, you alluded to the SEAM-RA trial presented by Jeff Curtis at ACR, where he showed that it's probably better to stop the methotrexate than to stop the expensive biologic etanercept, because monotherapy etanercept did basically the same as continued combination and whatnot. So that's and that sort of support is supported by the ACR guideline, but the UR guidelines say stop the expensive drug first, and their rationale for that, as explained in the manuscript, was that they felt with biologics, if you stop it and you lose control, you can more quickly recapture response as opposed to trying to recapture with methotrexate. What's your response to that UR position?
So I'm not certain that they actually, because the SEAM trial has been so recent, whether or not they incorporated that into their guidelines, which again were not 2019 guidelines. You know, there's certainly a rationale on a practical aspect of stopping the biologic. They're obviously more expensive. They're often harder to use and have more difficult with access. But I think it's pretty clear that stopping methotrexate is probably preferable to stopping the biologic.
But I want to make a comment to this. So the SEAM-RA, you have to remember, were patients who were treated with etanercept or methotrexate and treated to sustained remission.
6 months.
Right?
Right.
For a long period
6
of time.
months.
Right?
Well, 6 months is, that's the other question, is were they at remission long enough?
No, well, all right, I thought it was longer, but be that as it may, it's still at least 6 months, right?
Right.
And then they're stopping the methotrexate, and patients looked like they did the same, although there were still patients who did better with the combination. Right. I do want to say something about the ACR guideline, though. The ACR guideline is wrong. All right. So the question is it's expert opinion, and you did not say this. It is expert opinion, and I actually have questions about the experts. One reason, right? One reason.
Oh, yeah.
The reason is with ABBA, we've presented data with ABBA, and that was your example, right?
That is right.
With ABBA, if you discontinue methotrexate, patients do poorly. If you taper the ABBA, all right, many of those patients actually continue to do well. And if the experts actually had some common sense, right, they would go by the ULARC guideline, which is you can taper the ABBA, right? If the patient flares, you re-increase. So the discontinuation of the methotrexate, it's different than when you're looking at a JAK inhibitor and an IL-6 inhibitor, right?
Right.
It depends upon the molecule that you're looking at.
So the other thing that these trials don't really address is that if the role of methotrexate in combination with the biologic is to prevent an autoantibody response against the biologic, right? Then getting rid of the methotrexate in the long term may be detrimental. And therefore, I am cautious about stopping methotrexate completely in that patient population.
And then it may be a difference between the different molecules.
Yes,
right?
Exactly.
Yeah.
Exactly.
Right? And
Exactly.
One other, I want to make one other comment, and that was one of your cases where you had the patient with a C diet 10,
Yes,
right?
right,
And you want to know what to do.
right.
And the ACR guideline is the patients with low disease activity don't do anything. You're at a C diet 10. Don't do anything.
It just snuck over the line.
Right?
I'm sorry. There was an overseas comment.
Maya, you want to weigh in on that?
No, well, I'm not aware of the case, but I think this discussion about whether to first taper the conventional synthetic methotrexate or biologic, I think it depends on a whole host of reasons that have already been mentioned. The nature of the biologic drug or targeted synthetic, cost is an issue as well that certainly determines it. I think the TARA trial may have also influenced some of the thinking. So the European TARA trial that looked at either tapering TNF inhibitor or the conventional synthetic DMARD and then subsequent and vice versa that didn't show any apparent difference. And that informed some of the sense that because the biologic drug is more expensive from a cost effectiveness point of view, that may be appropriate. But I think, both Alan and Roy's points are well taken in that there may be an argument if the assumption is when we get our patients into sustained remission on biologic combination with methotrexate, that the biologic is the predominant drug that's essentially conferring that, and the methotrexate is providing some additional advantage either because of immunogenicity or some synergy mechanistically. So I think it's a tricky one, and I think often cost has been a driving factor in the whole tapering discussion rather than necessarily mechanism and biology, as it were.
And then there's with the patients one, I think a lot of the ACR guideline really has sort of favored maybe the patient over the cost, because patients usually want to stop methotrexate before they want to stop that biologic. Maya, I want to ask you about, again, your approach. You've been working on this topic of difficult RA, and you presented a number of scenarios that were instructive, but do you see an algorithm coming out of this? So the patient is a patient who's failed methotrexate and a TNF inhibitor, and now you need to move on. Where is the algorithm going? How are we going to do any better than flipping a coin? And what is EULAR plan to do about this?
Good question, and I think whether in the context of difficult to treat or refractory or the wider framework and concept of precision medicine, we haven't reached that yet. So the reality is, I think having an algorithm is tricky, challenging, and to be honest, I'm not sure it's the right approach because it sort of contradicts this whole concept of trying to tailor therapies to our individual patients. In the UK, we have a system through our NICE, the National Institute of Clinical Excellence, that initially actually invoked this prescriptive algorithm, and it's actually become slightly defunct now because there are too many permutations potentially. And in essence, when we tailor our treatments, in the absence of clear predictive biomarkers, we actually, even if we have that, we use the totality of the individual patient and disease profile. So comorbidity is important, the nature of the disease, the clinical profile, all these things factor into our decision making. And we don't have a way of still trying to really have a good algorithm for our individual patients. If we're brutally honest with ourselves, broadly speaking, it's still trial and error. There are some nuances, clearly, based on serological status, other factors, whether methotrexate, if you're going for monotherapy, certain therapies we may advocate over another, but that's not true precision medicine. So I think we're some way off there, and I think it still remains a very big challenge.
So I want to agree with Maya 100%. I think the biggest challenge in rheumatology is the biomarker test or tests that will predict who will respond to what safely, right? And until we have that, it really is just a guess, and then you take all the factors that Maya was talking about. I don't think that can be overemphasized.
I mean, I think this is going to be better resolved by artificial intelligence and machine learning and looking at large data sets so right now I am flipping the coin, or I'm going with my particular bias that, I like abatacept here, and you may like an IL-6 inhibitor in this situation, and who's to know whether it's right? But maybe if I knew that it was 7% better to do one over the other, would I really do that? At least I'd like my patient and myself to have that information.
And,
Okay.
and I think the other point is our expectations as well. So we often compare where we are with rheumatology and aspire to the oncology model. precision medicine, but actually, is it 100% being able to predict? No, it's not. And I think we have to manage our expectations. And the other issue is actually the dimension of response. And I sort of alluded to that in the talk in terms of how we define response and what determines response, what determines disease activity assessment. These are complexities in our interpretation. And then in trials, I think it's really difficult at the moment to be able to capture that.
I want to, Alan, give us your opinion.
So I absolutely, and the concern I think we all have is that whether or not we're creating artificial clinical subsets to suggest that one drug may be better than the other. So for instance, the things that may be valid or not valid, patients with high sedimentation rate and C-reactive proteins, we tend to give an IL-6 inhibitor to because those drugs have a dramatic effect on those clinical parameters. Or whether or not patients who are CCP positive do better with abatacept has been the subject of multiple studies. But the other factor that needs to be considered is comorbidities and safety in the choice of these drugs as well. And that's where this clinical decision-making often gets very difficult because it's not only the effectiveness you're looking at, but you're looking at safety of these drugs over time.
Yeah, I call that defensive prescribing, meaning once you get beyond your first or second biologic, all your choices are defined by what you can't use because of patient concerns or a
Right.
particular toxicity.
But there's one other point that Maya alluded to. It's patient access.
Right.
What drugs are available to the
Right.
patient? What can they afford?
Right.
Well, do you think that it's the case right now, at least in the United States, that beyond the first tier, that you're still restricted in what your secondary and third choice of a biologic is?
I think that sometimes you run into those problems. Yes, I do think that sometimes you do. It isn't as bad as the first tier, for sure, right? But there are companies that want you to do 1 or 2 or 3 before you can go to what you think and the patient thinks is the fourth choice.
And sometimes the choices are of totally different drug classes.
Right.
The next choices. So it's not as if they're giving you choices within a drug class. They're
Right.
giving you totally different drug classes as
Right.
preferred products.
I want to ask the question that I think all three of you kind of touched on in your presentations, and that is what do you do when the decision is all about pain? That becomes the reason why your patient is a difficult patient, why you're struggling with what your next choice is. Do the newer therapies that are touting pain as a great outcome, as you showed, Roy, are they going to be the right option? So why don't you each give us your own bias on managing pain, and as opposed to synovitis, per se, being the problem, what's your approach, Maya?
So I think it's a massive issue, and I think all of us in our practices have observed that in this era of actually we treat inflammation pretty well, I think, with the drugs that we have. Not universally, and the discussion we just had is that clearly there's still a trial and error approach. But broadly speaking, we treat inflammation pretty well. And if you look at what's a big factor in terms of unmet need, it's pain, as you say. I think we don't completely understand the drivers of it. We broadly assumed that a lot of this is central sensitization and fibromyalgia and put everyone in that bucket. I'm not sure that necessarily is the case. So I think there is some refinement in terms of understanding what the drivers of pain are. RA is a systemic autoimmune disease. There may be other mechanisms that we still don't understand. And then in the issue in terms of current therapies and whether there's some additional effects on pain, I think there still need to be the well-conducted studies to be able to actually stratify and phenotype patients for local synovitis and inflammation and pain and how these therapies do effectively address all those elements. The data we have from JAK inhibitors and others are mainly from post-hoc analyses. So they certainly give insights and give us a basis to generate, I think, legitimate hypotheses and more clearly demonstrate it. But I think future strategies need to address both those components. That only comes with an understanding of what's driving pain. So ultrasound, to me, gives us an additional dimension to assess the patient to see whether it's peripheral nociception, so our traditional paradigm that with local inflammation it's driving pain. But if in the absence of that, I think we still don't clearly understand what's driving it, and I think that's a huge research area.
Alan?
So, I always found fascinating that in my practice that the most common use of Vectra and the most common use of musculoskeletal ultrasound is to prove to the patient that their pain is not inflammatory in etiology. That's become the most useful, the most common use of these tools, and it reflects the fact that I think, as Maya was saying, that we just need to understand that there are pain pathways that are non-inflammatory or are not able to be assessed by our common assessments for inflammation, and I think that's a huge, huge issue in that population.
Yeah, I don't have anything to add to what Maya said. We've published 3-4 articles recently on pain in RA and some of these post hoc analysis, and clearly most of the pain you see in patients whose inflammation is under control, there are differences in drugs, but most of the pain actually is non-inflammatory, most of the pain. So we do have to understand the biomechanical and the biochemical manifestations of that to address that. And that's why I'm thinking that something like the gmcsf, which is actually involved, or the IL-6 inhibitors, including the targeted synthetics, may be somewhat better than some of the other mechanisms. But we're really in the infancy.
Roy, a few questions about the JAK inhibitors and the differences. You know, you presented another JAK1 inhibitor. What are the differences between all the JAK1 inhibitors? Or maybe answer the broader question. We now have a number of options and more to come. How do you choose which one to go with if you're not mandated by insurance, which one to use first?
The JAK1 inhibitor or a JAK inhibitor?
Well, it's both. I got both questions. So
okay.
There's a number of different JAK1 inhibitors. What's the differences between them?
All right. So there are 5 JAKs approved worldwide. All right. So we have tofa, we have Barry. Unfortunately, we just have 2 milligrams in the U.S., which works, but not as well as the 4. We have upadacitinib and filgotinib in many places in the rest of the world. If you take a look at the clinical results from the trials, all right, each one of them, I don't think you can tell a difference. All right, I really don't think you can tell a difference. And so I'll make one statement. So we did the trial of upadacitinib versus adalimumab. Upadacitinib was better. We did baricitinib versus adalimumab. Baricitinib was better. We did tofacitinib versus adalimumab. It was the same. Filgotinib was better. If you did a head-to-head trial of the 4 JAKs, I doubt that you would find any difference. All right? So in the test tube, clearly there are differences. And with respect to safety, with filgotinib being more JAK1 selective, I think you see less herpes zoster, you see a little bit less serious infection, but malignancy is the same, MACE is the same, VTEs, we don't have enough information to know, but they do occur. So I don't know that there really is a big difference. So which one will I use? I could say, well, the one I've used for so many years I'm comfortable with. I could say the one that the patient's insurance has. I could say the one that the patient wants to take. I mean, how do you select which one? I don't have a test to tell me which one the patient's going to respond to.
Since you diplomatically and correctly say that they seem to be equivalent, does that change your thinking about switching from one to the other? If I don't do well on filgotinib, will I do well on pepocitinib?
Oh, absolutely the same. So there's no reason to switch from one to the other. It's like a TNF. Patient fails in etanercept, don't go to another TNF. That is,
wait, that's what the whole world does.
That is 1998 thinking, right?
That's what the world's still doing.
Yeah, well,
most people are using a second and sometimes a third TNF inhibitor.
It's 100% wrong. The chances of switching from one TNF and responding to a second TNF, even with a primary failure, we've shown this, is the same as switching mechanism of action. All right, patients do respond. And there are now case reports, and I'm sure Maya can probably speak to this much better because you have so many JAKs, and we're getting the same information here in the U.S. If a patient doesn't respond to tofa, they can respond to upadacitinib, or vice versa. So, yeah, the results in groups of patients are the same, but as Maya pointed out before, we don't have the test about what patient will respond to what drug selectively.
And so what we do in reality, so I agree, with TNF inhibition, it's interesting, isn't it? Because, again, broadly speaking, intuitively, one would switch class on an individual level. We have seen instances, and we've had trials like Accelerate and others that certainly suggest there may be benefit within class switching. And we're seeing the same with JAK inhibitors. I think the devil's a bit in the detail for our individual patients. And one of the slides I showed at the end was when we talk about response and non-response, we're very categorical about it. We're very binary about it. In reality, what we see is this spectrum of response. And we recognize that even within a same class, we can sometimes see contrasting responses, which are slightly inexplicable. And that's the known unknown. If you say on a group level, would you advocate it broadly speaking? Probably not. On an individual level, depending on, again, individual patient disease status, the nature of non-response, is it a true non-response? Is it partial response? Is a partial response a non-response? It's slight semantics. And how many treatment options available? All these feed in, I think, into the final decision as to whether you consider an intra-class switch. And the same as the TNF inhibitors at the time, the turn of the century, when that's all we had available, it forced us to do it. And we saw these sort of unexplainable responses. And I think the same applies with JAKs. Roy's absolutely right. We see, we've written on our experiences of intra-class switching where we see some benefit. We can't quite explain it. You wouldn't necessarily advocate on a group level. On an individual patient, you may well do, because options may be limited and there may be some argument to do it.
Catherine Dow, my colleague, has a virtual question. I really think that and I guess this is for Alan, but all of you can weigh in. I really think the ACR guidelines in choosing rituximab over biologics in patients with a history of lymphoproliferative disease is really unfortunate. Now with the pandemic and risk of COVID-19 complications, and that patients on rituximab do worse with COVID-19 based on the recent report from Strangfeld, would this change your mind about this particular recommendation? Again, it is an expert opinion recommendation.
It is, and it's clearly a conditional recommendation. And at some level, I do think that they took a little bit of an easy way out in that regard. But I think we're all questioning whether or not Rituxan is the only choice in that patient population.
So my particular view is I go with the data, and when you look at patients with lymphoproliferative histories, either a history before they got the drug or a history while they're on therapy,
right.
There's far more data for TNF inhibitors than any other drug, showing that it works just fine. So that's my go-to drug. I use the best drug. I'm not afraid. I don't know that anyone is any better, but so I really want to know from each of you, with a history of lymphoproliferative, what's your go-to, right. Or does it matter to you?
So if you remember, the history of this was when these original biologic agents, TNF inhibitors, there was concern that they caused lymphoproliferative disease, and I think that's been answered very well recently. So therefore, there should be a shift in thinking, and I just didn't think that the ACR really addressed that.
Yeah, so I want to add to that. So in my talk, the key point that I was trying to make was the difference between the TNFs, and there may be a difference between adalimumab and etanercept. We don't know that data yet. But the difference between TNF and TOFA was numerically different. But how do we know that the TNFs don't decrease the incidence of lymphoma in patients with RA?
Recent report from Sweden at ACR showed when it came down over time.
Which I think that they do.
Yeah.
And that TOFA reduces it as well, but not quite as much. And therefore, there's a difference. So they're both effective, right? But one may be a little bit more effective than the other, right, in terms of reducing lymphoma.
So the lymphoma incidence or recurrence is presumably driven or made worse or made better by control of inflammation. That's to your point. Right?
That would be my point. And I think and that's why I did all that history. All that history shows that when you really get inflammation under control, MACE events, malignancy events, most of them decrease.
Yeah.
Not lung cancer, right? Not lung cancer. But lymphoma does, certainly colon cancer does. They all decrease no matter what drug that you're using.
Maya, do you have a preference in those patients?
Yeah, well, I mean, I think I agree with you. I think Alan's point's well taken. A lot of it was based on history and the theoretical concern at the very start when TNFs were our first biologics, so we veered away from it. Intuitively, rituximab would seem safe because it's used to treat in lymphoproliferative, so that's why there's a natural inclination to go for rituximab. But Jack, I absolutely agree that there's a risk we've limited treatment options for our patients by retaining our historical concern with TNF inhibitors. So it's a point well taken. So I would consider TNF inhibitors as well, but I understand why rituximab is a natural bias to use because it's actively used as a treatment.
So I have a few questions on rituximab, and we're really talking about anti-CD20. So this is really for all of you. Patients on rituximab, how are you monitoring their immune status? Are you doing immunoglobulin levels? Is that an important assessment? How often does it factor into whether or not you retreat or not? Who wants to start with that one?
Alan can start.
So, yeah, go right. Go on, Roy.
No, please go ahead.
Well, I'll start.
You're probably.
Go ahead, Maya.
Go ahead, Maya.
So I think, we see with repeated Ritux exposure in a certain proportion of patients, there is a progressive hypogammaglobulinemia we see. And it partly depends on the trend as well. I do check immunoglobulin levels prior to administering rituximab, but the decision again is an integration of the trend we see, not absolutes of the IgG level, concomitant medication like steroids, comorbidity, etc. There are some patients where you see a progressive decline, and you know that with further rituximab, we are going to come to a point where the risk of potential infection outweighs the benefit. And so there is sometimes a limited lifespan for some groups of patients in giving prolonged rituximab therapy. So I do check the immunoglobulins. It's a way of almost risk stratifying a little bit for me. And there are data from observational registry data sets, et cetera, in terms of infections with persistent hypogammaglobulinemia.
Yeah, so I agree with Maya. So we saw this probably 10, 11 years ago. Where there was reduction in the immunoglobulins, and that was of concern. And there were reports from Genentech at that time, but it wasn't associated with serious infections. But recently, it has been shown that is problematic. So I think that as opposed to what I might have done 10 years ago, at this point, I would take a look at immunoglobulin levels. And if they're persistently low, I would be concerned.
So I too check them, and I often think that it just causes me like a rheumatologist to worry about everything a little bit. But it really depends on the situation that you're in. So many of my patients who are on Rituxan, this may be different than the European experience, are patients who end up on Rituxan because they were left with really nothing else at that point, and are doing very well on Rituxan. And those patients, I think, the risk, I think, is worth taking. But I think the issue about Rituxan is perhaps more relevant in patients who are on maintenance Rituxan for vasculitic disorders, and how we dose those patients over time, I think, is an important issue for that patient population as well. And perhaps is even more important for that patient population because there are not that many alternatives.
So, Jack, I want to just change the subject for a little bit because I want to make a comment about the ACR guideline. One of the real limitations of the ACR guideline is that they did go out and say you should be looking for LDA rather than remission, which I have problems with. I think there are times you want to do that. The biggest problem is they didn't define it. So if you're going to do LDA or remission by doing a rapid 3, it is very, very different than by doing a C-dye or an S-dye. And if you're doing it by DOS28-CRP, it's going to be very different than that as well. So I think that, practitioners, when you see this, if you want to follow the guidelines, you really have to think about which metric you're going to use. And I would strongly suggest, not being an expert because I wasn't on the panel, that you would use a stringent metric, not a weak metric, and a metric that does measure joints.
All right, folks, so we need to end our session. I want to thank our faculty, Maya Butch, Alan Matsumoto, Roy Fleischmann, a great discussion. Thank you very much.
Thank you.